I'm Dr. Timothy Geib. I've got Wade Hill here helping me today, one of our awesome scrub techs at Bone and Joint Hospital. Just going to kind of go through an exam of a shoulder for throwing athletes to kind of assess pathology and see how to potentially help those athletes get back to return to play. So essentially with this, we kind of look at a few different steps. The first would be kind of inspection, looking at the shoulder, kind of seeing is there any kind of postural issues that we may need to be addressing that may help the function of the shoulder in the positions of throwing. You put it in some extreme positions to generate the velocity and mobility that you needed to throw a ball as fast as you need to and accurately. So because of that, the base of the shoulder is actually the shoulder blade. So the shoulder blade is something that we look really closely at. So if we look at Wade, his posture is really pretty good. He's maybe a little bit we call protracted. You know, his shoulder may be a little bit forward here, as opposed to some people, if we can finally get their shoulder blade flush to their chest cavity. The reason that's important is for every 2 degrees of motion that we gain from shoulder motion in the ball and socket, there's another degree that comes from the shoulder blade. So if that shoulder blade is off and forward, then the shoulder itself sees more stress and strain, and that leads to issues where the shoulder starts to decompensate, and then the elbow can decompensate. So it's called the kinetic chain. So look real close at the shoulder blade. We look and see, is there any sort of winging of the scapula, meaning that the shoulder blade, instead of sitting flush like that, would be winged out like that. Again, that sets you up for failure in the shoulder and then down the arm. So his shoulder blade posture looks good as far as the actual position of the shoulders are equal. We don't see any winging of the shoulder blade on that. So that's initially looking at the inspection of the shoulder. So once we've done that, we'll look at range of motion. So initially we want to look and see what the mobility is. So if we have Wade go ahead and do forward flexion for us, we raise both arms at the same time. This gives us a baseline when we look at both shoulders on what the normal shoulder on the left would be as opposed to his dominant right arm. So he's got normal forward flexion. So if we come now from the sides, come from the sides and try and touch your hands over your head. So his abduction is equal on both sides as well. Now we'll look at internal and external rotation. So these are a little bit subtle. So we'll go out with your hands that way. That's external rotation, and they're equal on both sides. He's got good external rotation. So that in cocking phase would be important. And then how about if you kind of came back behind your back there and kind of spin around so we can see how far up his back he can go. So his internal rotation is good there. If he had a defect in his internal rotation, that may reflect a lack of follow through, and that's called GERD, and that's another rehab problem like the shoulder blade that needs to be addressed before you go trying to do anything else with the shoulder. So now we've done that, let's see kind of in the throwing position what you can do. So if we did the cock back phase as far back as you can, to act like you're going to initiate a throwing motion, it looks like it's equal on both sides. Now let's do the internal rotation here, and we'll follow through. So again, his internal rotation is really good, but that can be a morphologic thing that people with throwing, since they're little kids, develop an internal rotation deficit, meaning that they cannot quite get this arm followed through or this arm follows through. So when they have that, they start to decompensate the shoulder, and that motion becomes an issue for us. So initially inspection of both the motion and the shoulder blade, that's step one. Then we kind of get to the dynamic test of strengthening. So if you look at strength, if we keep his elbows in close here, we'll test his external rotators of his rotator cuff. So come back to neutral for me. I'm going to push in, you push out. This will test the infraspinatus and teres minor. And then we'll raise up here. He's got good strength there. I'll push down his forearm, so push up to the ceiling. This will test his supraspinatus muscle. And then we'll go to the front here. Now we're going to put elbows forward like that. I'm going to push back, you push forward. This essentially tests the subscapularis. So that's the strength component. So the rotator cuff, if there was weakness, obviously there would be give with that, and we don't see that in his scenario. So once we've done that, we do some special tests. So now if we were to test for a potential slap tear, we look at O'Brien's test. So if we can kind of come across your body like that for me, point your thumb up, and I'm going to push down, you push up. So you got good strength there. We asked if you had pain with that. If you did, that would reflect more AC arthritis, which would be here. Do the same thing position-wise, please, Wade, and then the same arm, I'm sorry. This one, they go to thumbs down for me. I'm going to push down, he'll push up. Now, if he has positive pain with that, that would be more of a positive test for a superior labral tear. So look at inspection, strength, and then special tests. So the other potential issues could be a biceps related issue. So the biceps could be palpated. You can kind of just palpate the front of the shoulder, and you can usually feel a little bit of a rope that you can run your fingers over. If they have pain over that area, that would be reflective of biceps tendonitis. The other test we can do for that would be called a speeds test. So he would extend his arm like that, push down on the front of his forearm, and he lifts up on it. If that elicits pain in that biceps, that's reflective of a biceps tendonitis problem. The last one would be called a Jurgensen's test. So if you were to kind of bend your elbow like that, I'm going to grab your wrist and I want you to kind of rotate your arm like that. So the biceps is not only just an elevator of the arm, it's usually more of a supinator, which is palm down to palm up. So his palm's down, I grab his wrist, I apologize because I'm going to squeeze, and he rotates his hand like that. If he has pain up in the biceps through there, that could be an indication of biceps pathology as well. The other ones we'll probably do a little supine look at too, so we may kind of get a bed, and we'll do that here in just a second. So these last couple of tests are more labral specific. So again, labral pathology in shoulder athletes is generally a slap area, but sometimes they have instability issues. Some of those can be multi-directional, where they're generalized globally lax, where if they have the capacity to kind of hyperextend their elbows, or if you take their wrist and flex it down, try and push their thumb to their forearm, that may display evidence of that the shoulder globally is loose. So you can shift to the front, to the back, and down. Those things are things that are more rehab driven to try and help. The other labral pathology, which is a different kind of instability, can be related to the frontal labrum. So if we were looking at an anterior labral potential tear, we would take his arm and we'd rotate it back as far as we can. As we get to that hyperabducted external rotated position, sometimes they'll feel apprehensive. They'll feel like the shoulder's going to shift out. So if that happens and they feel that way, you put your hand on the front of the shoulder and you push back. That's an apprehension, augmentation, relocation test. So if they feel like the shoulder's going to shift out, that's because the front labrum may be torn and they have pain there. The other area we can kind of have pathology is in the back. So a battered shoulder is somebody that may have swung really, really hard and their shoulder shifted out the back, and that can create labral pathology in the back. So that's a problem that we can load the shoulder. We go into adduction, internal rotation, and we push back on the shoulder like that. They would have pain in the back of the shoulder, sometimes some clicking and popping. The last one would be a crank test. So if we kind of dynamically recreate the throwing motion, but we load the shoulders, we're going into an abductive external rotated position. I'm going to push in on his elbow and load that shoulder. And as we kind of internally and externally rotate, we're trying to pinch the labrum between the ball and the socket, and that clicking or popping may cause pain with that. So those are kind of some labral pathology tests that can kind of give us some information about whether or not we may need to dive in a little bit deeper with imaging, whether we need to just kind of focus on rehab or a combination of both. So thank you, Boyd, for your help. Appreciate you very much.
You're kidding, I got to lay that